initial trauma evaluation, radiographic imaging guidelines, types of head injuries, managing intracranial pressure, coagulopathy, and finally, spinal injury considerations. No filler, just maximum educational value. Starting right off with Section 1, Initial Trauma Evaluation. We begin exactly where you do when the patient rolls through those doors, primary and secondary surveys, focusing on consciousness and those crucial physical exam findings. You already know the Glasgow Coma Scale breaks down into eye, verbal, and motor responses. But here is the absolute bottom line you cannot afford to miss. A total score of less than 8 means the patient literally cannot protect their airway. You intubate immediately. There is zero gray area here. Moving to the physical exam, we methodically palpate the cranial vault and mandible, check pupillary size, but hey, do not use pharmacologic dilators on these patients. Unilateral dilation is your early warning sign for brain herniation, and you definitely don't want to mask that. Also, keep your eyes peeled for periorbital hematomas, raccoon eyes, along with CSF rhanorrhea and hematempanum. These are your classic high-yield red flags for a basal skull fracture. For penetrating neck trauma, it helps to mentally map the neck into 3 anatomical zones to hunt down vascular and aerodigestive damage. Zone 1 is the thoracic inlet from the manubrium up to the cricoid cartilage. Zone 2 is the mid-neck, cricoid up to the angle of the mandible. And Zone 3 takes you from the mandible all the way up to the base of the skull. Quick rule of thumb, if the injury doesn't violate the platysma muscle, we consider it superficial. All right, Section 2, Radiographic Imaging Guidelines. Who actually gets a scan? We need strict, evidence-based criteria because we can't just scan everybody, but we definitely can't afford to miss a lethal bleed. This is where you lock in the Canadian CT head rule for patients with a GCS of 13 to 15. Memorize this checklist. Patient is 65 or older. Scan. GCS drops below 15 after 2 hours. Scan. Signs of an open, depressed, or basal skull fracture. 2 or more episodes of vomiting. Retrograde amnesia lasting 30 minutes or more. Scan, scan, scan. Any single hit on this list dictates an immediate non-contrast CT. Now, for the neck, our biggest fear is a blunt cerebrovascular injury. To stop a massive stroke before it happens, we apply the Denver screening criteria. If your patient has signs like a cervical brute, an expanding hematoma, or high-energy risk factors like a Lefort fracture or basilar skull fracture, you need to grab a CT angiography right away. Clearing a C-spine collar is a strict algorithm, and it completely hinges on one question. Is the patient cognitively intact? If they are alert, asymptomatic, and have zero deficits, that collar can come off. But if they have tenderness, you get a CT. Now, if they are not cognitively intact, they stay immobilized and you scan them. And listen, a negative CT in this scenario does not clear them. That collar stays on until you get a reliable clinical exam or an MRI. Moving straight into Section 3, Types of Head Injuries. Let's actually identify the pathology on those scans. It is all about the shape. An epidural hematoma looks like a classic biconvex or lens-shaped hyperdensity. This is almost always from a temporal bone fracture slicing open the middle meningeal artery. Contrast that with an acute subdural hematoma. That one shows up as a hyperdense crescent hugging the curve of the brain, usually from shearing forces tearing delicate bridging veins. Deeper down, cerebral contusions show up as punctate hyperdensities, often in a coup-counter-coup pattern, where the brain basically bounced against the skull base. Intraparenchymal hemorrhages, on the other hand, are larger focal bleeds. These are incredibly dangerous because they carry a massive risk of expanding right into the ventricular system and causing acute hydrocephalus. Section 4. Managing intracranial pressure. How do we control the mechanical pressure cooker inside the skull? Here are your absolute target numbers. You have got to keep the intracranial pressure below 20 millimeters of mercury. Meanwhile, your cerebral perfusion pressure, which is your mean arterial pressure minus your ICP, has to stay comfortably between 50 and 70. Whatever you do, do not let these patients tank their blood pressure. A systolic under 90 is a one-way ticket to terrible outcomes. Because the adult skull is a rigid, unforgiving box, we escalate therapies using a strict staircase approach. Step 1, intubation, sedation, and pain control to stop agitation. Step 2, place a ventricular drain to pull off CSF. If the ICP is still above 20, Step 3 is hyperosmolar therapy, like mannitol or 3% hypertonic saline. Steps 4 and 5 escalate to induced hypocapnia, hypothermia, and metabolic suppression with barbiturates. And if all else fails, Step 6 is your decompressive craniectomy. Section 5, Coagulopathy and Medical Management. The brain relies on the rest of the body, so systemic optimization is crucial here. If your patient is coagulopathic, you have to stop that hematoma from expanding right now. On warfarin, push 10 milligrams of IV vitamin K and give 4-factor PCC based on their INR. And notice that 4-factor PCC is also the go-to reversal agent for dabigatran, rivaroxaban, and apixaban. You are aiming for 2 non-negotiable targets, an INR of 1.4 or lower and a platelet count of at least 100,000. To prevent early post-traumatic seizures in patients with a GCS under 10 or an intracranial hemorrhage, we use a 7-day course of prophylaxis. Our clear favorite here is levetiracetam or Keppra over phenytoin. Why? Keppra is an absolute game changer because you don't have to monitor serum drug levels, it has a much better side effect profile, and it is infinitely better if the patient has underlying liver issues. You also need to watch for wild fluid and sodium shifts. Diabetes insipidus causes massive, dilute urine output, leading to hypernatremia. On the flip side, SIAD and cerebral salt wasting syndrome present with hyponatremia and dumped urinary sodium. Know the difference so you can correct it fast. Wrapping things up with Section 6, Spinal Injury Considerations. Let's look at the biomechanics of the spinal column. This 3-column model is absolutely crucial for instantly figuring out if a spinal fracture is mechanically stable or dangerously unstable. You've got the anterior, middle, and posterior columns. The rule is simple. An injury to just one column is generally stable, but if 2 or more columns are compromised, that spine is unstable. Medical management for spinal cases has really shifted, so pay attention. We actually do not blast these patients with high-dose steroids anymore. Current evidence just doesn't back it up. What we do aggressively initiate is early DVT prophylaxis within 72 hours. Also, keep in mind that spinal cord injuries can knock out sympathetic tone. That means these patients are at a high risk for sudden hypotension and need rigorous blood pressure monitoring in an ICU setting. All right, let's put it all together to test your rapid revision. You've got a 27-year-old motorcycle crash victim. He's had some emesis, his GCS is 14, vitals are stable, but you notice significant bruising right behind both ears. Based on what we just covered, what specific bony injury is hiding behind that redness? And, looking back at the Canadian CT rolls, what exact imaging modality do you need to order immediately to save this patient's life? Think it over, lock in your answer, and I'll see you in the next explainer.